little drink.
Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Wolf Petersen from Berlin, Germany. Professor Petersen is the director of the Orthopedic Department at the Martin Luther Hospital in Berlin, the Academic Hospital of the Charité. He is specialized in sports trauma, osteotomy and arthroplasty, and certified by the German Knee Society. He's a past president of the German Knee Society and vice president of the German Sports Trauma Society, and also serves as their board member. He's also the chief editor of the Knee Journal and serves as editorial member of the Operative Orthopedics and Traumatology, as well as the Arthroscopy, the journal of the AGA. He's chairman of the upcoming 10th Berlin Osteotomy course for 2023, and also the chairman for the 13th German Arthroscopy course for 2023. He's published widely and has more than 400 PubMed listed scientific publications to his credit. So today is my great honor to introduce you to Professor Wolf Petersen from Berlin, Germany. Over to you, Professor.
Yeah, thank you for this kind introduction, and also for the invitation to give this presentation here on this platform. So, and it's a very big pleasure for me to talk about high tibial osteotomy for the treatment of medial osteoarthritis of the knee. Okay, so my presentation doesn't move.
You can use the cursor on the left-hand bottom, Prof.
Here?
Yes.
Oh, yeah, okay. Okay, yeah, let's talk about, first, so it's more or less a basic lecture about indication, about preoperative planning, about surgical technique for high tibial osteotomy, and about results. Let's start with the indication. When we look to these X-ray, we see that we have two surgical options for end-stage medial osteoarthritis, which is the total knee arthroplasty, of course, and the unicondylar knee arthroplasty. So the big question is, why do we need an osteotomy for the treatment of medial osteoarthritis? And when we go to the literature, we all know that our previous studies have shown that there's a 20% dissatisfaction rate following total knee arthroplasty. But a newer systematic review has shown that this dissatisfaction rate has decreased from 20% to 10%. And to 7.3% when all complications are excluded, which is good news. But still, yeah, a high dissatisfaction rate. And from other studies, we know that patient satisfaction is significantly lower among patients with less than 55 years of age, and also in patients with low preoperative pain and high preoperative levels of physical activities. And we also know, when we look to the unicondylar joint replacement, that the revision rate, this is a study from the Swedish arthroplasty registry, that the revision rate in patients under 55 is much higher compared to older patients, which are older than 75. Therefore, we have a surgical treatment gap for less advanced osteoarthritis stages, and we need treatment options for younger and active patients, and for patients with less advanced stages of osteoarthritis. And yeah, this gap can be filled by the high tibial osteotomy. So let's look to the role of varus deformity for the development of osteoarthritis. When we look to this drawing, we see that the leg or lower extremity is loaded by the ground reaction force, which goes from the center of the foot to the center of our body. And this creates a so-called adduction moment, which is a measure for the load on the medial compartment. And when we look to to this adduction moment in the patient where the mechanical axis, which is this black line here, goes through the medial compartment in a patient with a varus deformity, then this knee adduction moment increases significantly. And we know from many biomechanical data and studies that the varus deformity leads to increased load of the medial compartment. And we also know that an increasing degree of varus alignment is associated with the progression of osteoarthritis and also with the development of knee osteoarthritis. What is a significant varus deformity? How is this defined? We have two definitions. First, the mechanical axis deviation. And per definition, a mechanical axis deviation of more than 50 millimeters is a significant varus deformity, or the hip-knee ankle angle, HKA angle, which would be more than 5 degrees. This is a medial axis deviation, and this is a hip-knee ankle angle. Yeah, when we look to this patient, we see this is a patient with the varus deformity, but we see that the joint, we can also observe the lateral joint opening when load is applied to the knee, and this is called the so-called varus thrust phenomenon. We can also see here in the whole leg X-ray. And this is a patient who has two types of varus deformity. He has a ligamentous type of varus deformity and a bony type of varus deformity. And we have three different types of varus deformity. This is very important for our indication. We have this osseous or bony varus deformity, which is defined by an medial proximal tibial angle, mechanical medial proximal tibial angle of less than 84 degrees. The normal value is 87, or a tibial bone varus angle higher than 3 to 5 degrees. But the medial proximal tibial angle is, in my clinical practice, this angle is for me more relevant. Then we have this ligamentous laxity, as you have shown it in the previous case, which is caused by a laxity of the lateral ligaments and the ACL. And with this lateral laxity, the mechanical axis can shift to the medial compartment. And we have a third varus deformity, which is an articular varus, which is caused by a loss of the medial joint space by cartilage injury or caused by cartilage damage. In several cases, as you've seen it in the previous case, we have a combination of two types or even three types of varus deformity. And why is this classification important? It's important because these both types are very good indication for an osteotomy, because in this case we have a bony deformity, and the bony deformity we can correct. And in this case, the deformity comes from the joint. In these cases, it's very difficult to correct it because we can only correct it by an overcorrection of the bony deformity. Therefore, this is the ideal indication for unicondylar joint replacement. And the study has shown that the effect of varus deformity or the tibial varus deformity has a significant outcome on the results after HTO. We had two groups in the studies. Group 1 with tibial varus deformity, group 2 with no tibial varus deformity, and this study has shown that the PROMs, the patient-reported outcome measures, like as the KSS or the WOMAC scores, were significantly worse in group 2 than in group 1. Therefore, this tibial varus deformity is one indication criterion, a very important indication criterion, if we would like to perform an HTO in a patient with medial osteoarthritis. So we have the varus type is not the only indication criterion. If we compare the criteria for the unicondylar joint replacement and HTO, it's also the age. In all unis, we should look for an age more than 55, in HTOs less than 65. In unis, low activity level. In HTO, high activity level. Varus type, I talked about this before. OA grade, in UKA, 3 to 4, according to the Kelvin allowance scale. The best is a bone-to-bone situation, in my opinion. And here in the HTO group, it's better if we have a little joint space left. So the stages 1 till 3 are good indications to perform an osteotomy. Symptoms, severity of symptoms, severe symptoms in the UKA group and HTO in the moderate group. And then we have in both groups risk factors. One risk factor for the unicondylar joint replacement is the instability or a decreased range of motion. And in the HTO group, obesity and smoking, because both factors can impair the bony healing. So 2 case presentations. 52 years, male, active tennis player, osteoarthritis grade 2 to 3. We can see here the mechanical distal femoral angle, which is 88 degrees. Normal is 87. And we have a decreased mechanical proximal tibial angle, which shows us that this patient has a bony deformity of the tibia. And this case patient fulfills many indication criteria for an HTO, which is a bony deformity, but which is also the age and the activity level and the OA grade. So in this patient, we performed this medial open wedge HTO. Another case, 67 years, also male, active, also tennis player, but very high pain, no improvement with non-operative treatment, only a slight varus deformity, and we see that most of the deformity comes from the joint. So the proximal tibial angle was quite normal, with 87, as you can see here in this picture or slide, and also the mechanical lateral distal femoral angle was quite normal, 86, normal 86.6, normal is 87. So in this case, unicondylar joint replacement, in this case here with the fixed bearing, is an ideal option. And in these cases, I try to leave a slight varus deformity, not to perform an overcorrection. Yeah. So these are the indication criteria. Yeah, in both cases, I think the indications were quite clear. We have some in the clinical practice, we see also some cases which are not so clear, but then it's quite important to weight all these indication criteria against each other and find an individual solution for this patient. One test which can be performed, especially if the patient is skeptical because of the procedure, it's a brace test. In these cases, we apply an unloader brace, and the positive brace test is defined as pain relief medially without initiated symptoms laterally. And we have to make clear that this is a test which is only, or that the brace can only act for the ligamentous varus component of the deformity. Therefore, if the test is negative, it does not say that that an HTO is contraindicated. Yeah. Another indication is the focal cartilage damage. As you can see it here, in patient with an autologous chondrocyte implantation, here combined with an HTO. And this study of Tom Minus has shown us that if we perform cartilage procedures or cartilage repair procedures, then the survival rate of these procedures here, such an autologous chondrocyte implantation, is much higher if we perform additional tibial osteotomy than without an tibial osteotomy if there is a varus deformity. The next thing is we looked the previous slides. We looked only for the frontal plane or the coronal plane, but we have also looked to the sagittal plane. And in the last years, we learned a lot about tibial slope and instability. We learned that an increased tibial slope leads to an increased tibial instability. Therefore, also in patients with instability, an increased tibial slope could also be an indication to perform a tibial osteotomy to decrease the slope. This is a landmark study from an Australian group around Leo Pinchevsky, published by Webb and co-workers, and they have shown that when we have a tibial slope of more than 12 degrees, then this tibial slope increases the risk of rupture after an ACL reconstruction of about approximately 60%. Therefore, an indication from slope-reducing osteotomy is if we have a posterior slope of more than 12 degrees. So, in conclusion, for the first part of this presentation, is the osteotomy of the knee is indicated in unicompartmental osteoarthritis associated with varus deformity. These are the indication criteria: age, young age, activity, varus deformity, bony varus deformity, or instabilities. The brace test can be helpful. The negative brace test does not say that that there is a contraindication against an HTO, and the osteotomy should also be considered in focal cartilage damage associated with varus or valgus deformity, and in cases of slope deformities or sagittal deformities combined with failed ACL reconstructions. This is a useful patient information. You can scan this QR code with your iPhone to receive this patient information, because in some cases it is not so easy to convince the patient about this procedure. And this patient information can help you to explain this procedure to your patients. Let's go on with the planning section. Failing to plan is planning to fail. This is a well-known citation of John Charnley. And when we look to preoperative planning, we have first to look where the deformity is. And in this picture, we see that a valgus deformity is not always located at the femur, can also be located at the tibia, as you can see it here. And also the varus deformity must not be located always at the tibia, can also be located at the femur. So in these cases, we perform the so-called malalignment test. We determine the medial axis deviation. And as I told you before, mechanical axis deviation of more than 50 millimeters to the medial side is a significant varus, and a mechanical axis deviation of more than 10 millimeters to the lateral side is per definition a valgus deformity. And then we should check our axis. First, we perform the malalignment test to check if we have a varus or valgus deformity, and then we should determine where the deformity is, because we have to find out where we should perform the correction. Therefore, we measure the lateral distal femoral angle, which is 87 plus minus 3 degrees, and the proximal medial tibial angle, the mechanical proximal tibial angle, which is also 87 plus minus 3 degrees. And if we have a MPTA of less than 84, then we have a significant varus deformity of the tibia. And if we have an LDFA of less than 84 degrees, then we have of more than 91 degree, then we have a significant varus deformity of the femur. And the aim of our planning of our osteotomy is to keep the joint line almost horizontal and not to change the joint line. Therefore, we should perform the osteotomy at the bone where the deformity is. Yeah, aim is a horizontal joint line. Example for preoperative planning, we see here the malalignment test with a significant varus deformity, varus angle 10 degrees, MAD 32 millimeters. We have an MLDFA of 87 and an MPTA of 81. So this is an optimal indication for tibial osteotomy to correct the deformity. And another case here, we have a severe varus deformity with an malalignment test of 45 millimeters. The mechanical axis runs completely out of the joint, and mechanical angle of 15 degrees. Then when we look to the MPTA, 82 degrees, which is a tibial varus deformity. But when we also look here to the LDFA, it is 94 degrees. And in this case, we have a tibial and femoral varus deformity. So this would be, for me, an ideal case to perform a correction by a tibial and femoral osteotomy. Yeah, this slide summarizes the results of this malalignment test. Yeah. Medial deformity of more than 15 millimeters, or lateral deformity of 10 millimeters, varus valgus, and then we have to look if we have a femoral varus deformity, tibial varus deformity, or femoral or tibial valgus deformity. Then the preoperative planning. For the preoperative planning of our osteotomy, we use the method according to Miniaci. which was published or described in a paper which Miniaci published together with his senior author, Roli Jacob. And he had the idea of this planning method. For this planning method, we first draw the mechanical axis, which connects the center of the hip with the center of the ankle. And then we draw the new mechanical axis, which mostly goes here to the lateral tibial spine. Then we determine the osteotomy plane. And then we draw two lines from the osteotomy plane, line 1 and line 2, which connect the hinge of the osteotomy with the end of the mechanical axis 1 and the end of the mechanical axis 2. And the angle between those lines is our spreading angle. And when we know the length of our osteotomy, we can apply the length of the osteotomy here to line 2 or line 1. And at this level, the distance between both ends of the length is the height of our osteotomy. This is the spreading height. Yeah. And for the osteotomy, we should know it should start around about 30 millimeters below the tibial plateau, because later we will see that we stabilize the osteotomy with an angular plate fixator, and we should have enough space to for the screws of this angular plate fixator, and we aim this osteotomy towards the hinge of we aim the hinge of our osteotomy towards the tip of the tibiofibular joint. This has several reasons. We should have a distance of more than 1 centimeters to the tibial plateau here to prevent a so-called type 3 hinge fracture. And we should be high enough to prevent the type 1 hinge fracture here. If we have a type 2 hinge fracture, then the ligaments of the tibiofibular joints have enough capacity to stabilize the hinge. Yeah, you can see it here again. Yeah, this space is needed for the locking screw of the plates. Then we aim our osteotomy here to the tip of the fibula to use this tangent band effect. If we are too high, there's a chance to get a type 3 hinge fracture, which runs into the joint, the lateral joint line. If we are too deep, then we have the problem or have the risk of the so-called type 2 hinge fracture, which has a bad prognosis regarding healing. And how do we plan osteotomy? I told you in most cases, the osteotomy goes through the lateral tibial spine. It depends a little bit on how severe the cartilage damage is. If we have no cartilage or joint space narrowing, or in cases of cartilage repair, we aim on a nearly neutral axis. If we have an OR grade 1 or 2, we do a slight overcorrection. And if we have an OA grade 3 or 4, we try to go through the lateral tibial spine to get a little overcorrection. Okay, let's talk. This was the planning section of my talk. Let's talk about the surgical technique. The working horse of correction of varus deformity today is the medial open wedge osteotomy. It has several advantages. No osteotomy of the fibula is needed. The osteotomy is more precise than the lateral closed wedge osteotomy. 3D corrections are easier. And in case of additional ACL surgery, we have the same approach. However, this osteotomy is also associated with several risks. There is a risk of patella infera, because we spread the osteotomy below the insertion of the patella tendon. So if we have a patella infera or patella baja, then we could modify our osteotomy by performing this ascending part of the osteotomy in a descending way. This is possible. The disadvantage of the descending osteotomy is that it's a little bit more unstable. Another risk is we have the potential to lengthen the leg. So in cases of a leg length discrepancy of maybe more than 1 centimeter over length of the surgical site, then we should consider to perform a lateral closed wedge osteotomy. And one problem is also we have always the risk of increase the tibial slope because of the triangular shape of the proximal tibia. Therefore, there are several tricks how you can inference the tibial slope by performing the osteotomy. I will show you it later. Here also you can, if you like to download the surgical technique, you can scan this QR code here on the right side. Yeah, we always work with a movable leg holder. This is advantageous because we perform the osteotomy in flexion to protect the neurovascular structures. We do the osteosynthesis in extension to control the slope. Therefore, because of these both flexion angles, the movable leg holder is advantageous. And I always operate with the application of a tourniquet, but I do not inflate it to control bleeding or to see if we have a vascular injury. I always preoperatively we applicate 1 gram tranexamic acid to prevent bleeding and hematoma. You can see it here. This is some literature from our group. You can also scan the QR codes here if you would like to read the full text papers. You can see it here in the schematic drawing. Tranexamic acid prevents bleeding. We know it from total joint replacement, which leads to less hematoma, less intra-articular effusion, less pain, and better range of motion. And in these both studies, we saw no difference in thromboembolic events. Therefore, I think it's a very good perioperative application if we give our patients tranexamic acid also in medial open wedge HTO. Yeah, then the approach is a longitudinal incision of approximately 8 centimeters, always in longitudinal incision to anticipate a total knee arthroplasty. And we should do the incision and the osteotomy in the flexed knee to get more distance to the neurovascular structures of the popliteal fossa. I always perform an additional arthroscopy to treat interarticular pathology, such as microfracture, meniscus surgery, or do a notchplasty in cases with an extension deficit. Then I place first human retractors below the patella tendon. These are the hamstring tendons, and here you can see the the superficial medial collateral ligament. These structures should be exposed via the incision, and then we have to do a so-called SMCL release with the respiratorium. Here see the hamstring tendon, the superficial medial collateral ligament, and this is released by this respiratorium. And we do this because we do the osteotomy in between the inversions of the superficial medial collateral ligament. If we do not perform the SNCL release, we produce can produce a hypercompression in the medial compartment immediately after the osteotomy, and this would not be very beneficial, especially if we perform a cartilage resurfacing procedure. Then it's very important to protect the neurovascular structures by a human retractor. I always use a radiolucent retractor. This is quite comfortable because then you have to not to take it in or take it out when you do your fluoroscopic controls. Then guide wire placement under the guide wire for your saw under fluoroscopic control. Here, as I told you before, it aims on the tip of the tibiofibular joint. We should leave a space of approximately 30 millimeter. And in most cases, the guide wire start approximately 5 millimeters above the hamstring tendons. Then the biplanar osteotomy, it's very important to cool the osteotomy, the saw. During performing the osteotomy, I start with this oblique horizontal osteotomy, and then here the ascending osteotomy. The biplanar osteotomy is advantageous because of the high initial instability. Problem is the patella baja, as I told you before. Therefore, in cases with patella baja, we should use this descending type of osteotomy, or also in cases when we have an osteotomy gap of more than 12 millimeter if we do not perform a double level osteotomy. Then we spread the osteotomy gap with sigils. And we also should make sure with the sigil that the posterior cortex, the osteotomy of the posterior cortex is complete. And for the osteotomy, in my experience of the posterior cortex, the sigil is much safer than the saw to protect the neurovascular structures of the popliteal fossa. And then we replace the sigil by an osteotomy spreader. Go to in extension and spread the osteotomy to the level of our preoperative or the amount of our preoperative planning. And it's very important to place the spreader in the posterior aspect of the osteotomy to prevent an increase of the tibial slope. And when we look to the tibial slope, I told you before that there's always a risk to increase the tibial slope in these osteotomies. So if we have a normal tibial slope or an indicator for not influencing the tibial slope is if we have this converging osteotomy gap, which is normal because the tibial has a triangular shape. And then we have to look when we want to influence the slope, we have to also look to the localization of the hinge. And these studies here, these three studies have shown that if we have a posterolateral hinge, then we have the tendency to increase the posterior tibial slope, which can be good or can be beneficial if we have a case of PCL, additional PCL insufficiency. But in most cases, we want to have a neutral tibial slope or even decrease the tibial slope in cases of additional anterior cruciate ligament instability. So in these cases, we should try to get a lateral tibial hinge. Therefore, we have to really take care to complete the posterior part here. And as I told you before, for this, the sigil is quite advantageous, or even place the hinge in the anterolateral aspect of the proximal tibia. And this is especially, or can be especially performed if we have an ACL, additional ACL insufficiency. So by the localization of this, the localization of the lateral hinge has a very large effect on the posterior tibial slope. Then I always control the osteotomy with a fluoroscope. I have a metal rod for this. I do not use a cable. And then we check it by connecting the center of the hip with the center of the angle, and then we see here how much our amount of correction is. And as I told you, in most cases, the lateral tibial spine is a good amount of overcorrection. Then for osteosynthesis, we should use an angular stable plate fixator. Here I use the AP Logtech plate. This is a small, which has an ideal size in my opinion, and has a very good stability. It's not as big as a Tomofix plate fixator, but you can use the Tomofix, of course, as well. I think this is a little bit more comfortable for our patients. So osteosynthesis is also performed in full extension. You can see here the plate fixator in place. I use a temporary fixation with the K-wire. You can see here the spreader in the posterior aspect and the radiolucent Hohmann retractor. And I always place an a post here under the foot to get really a full extension of the knee. Then for plate positioning, the screws should be approximately, the proximal screws should be approximately 1 centimeter subpudendal to the joint line. And then you can apply an optional compression to the lateral tibial cortex, as you can see it here in the schematic drawing. I must admit, in most of my cases, I do not do this application of the compression, and I've seen in not using this techniques of about more than 15 years that the osteotomies heal without this optional compression. But most angular plate fixators allow this technical trick. Yeah, then the osteotomy is completed. You can see it here. Yeah, it's not a very big incision, so it's almost minimally invasive, and you see here the plate fixator in place. As the leg gap is larger, I apply allogenic bone chips to the osteotomy gap. Not only to promote healing, but also to prevent bleeding. And because we have seen if you do this, if you apply this bone chips to the patient has a little less postoperative pain, maybe because of less hematoma, because the osteotomy gap is filled with these chips. Here you can see the postoperative or the immediately or intraoperative X-rays with a fluoroscope. Yeah, I normally do one bicortical screw here and 2 monocortical screws distally. And it's also important here to check the slope here on the lateral view. I will show you a short video of this technique. Here's the medial approach, then the MCL release, just 1 minute, the radiolucent retractor. Then the guide wires, the biplanar osteotomy with cooling, then spreading the gap with the sigils. So you can see it here. Then put the spreader to the posterior aspect of the osteotomy. Then control it with a fluoroscope and perform the osteosynthesis with the angular stable plate fixator. As you can see it here, then we always use a torque screwdriver to control the torque. Here you can see the X-rays, postoperative X-rays again. Complications, to prevent complications, to prevent nerve and vascular injuries, operate or do the osteotomy in flexion, use this posterior human retractors. Prevent hinge fractures, spread slowly, osteotomy towards the top of the tibiofibular joint. Under an overcorrection, preoperative planning and use of intraoperative fluoroscopy. Increase postoperative slope, spreader posterior, and look for the hinge locations and pseudarthrosis, cooling, and use of an angular stable plate fixator. So rehabilitation, in normal weight patients, I use partial weight bearing for 2 to 3 weeks with full range of motion, and in overweight patients or in patients where I have type 1 hinge fracture, I perform 6 weeks partial weight bearing and full range of motion. If we have a patient with a neutral axis and a slope deformity, we can also perform an anterior closed wedge osteotomy. You can download the PDF of this technique here with the QR codes and also the video, because this technique has described by our group some years ago, and it is published in Arthroscopy Techniques. So this is an anterior closing wedge osteotomy. A case presentation which shows us how far we can go with the indication for this osteotomy. This is an active male patient, 52 years old, and so he has two factors or two indication criteria for an HDO: activity and age, but he has a very severe deformity. And if you would show these X-ray to orthopedic surgeons on an arthroplasty congress, and I think 90% of our colleagues would say, okay, in this patient I would do a total joint. The patient didn't want that. I also offered him to do a total joint. He said, okay, no, I'm active, I'm still playing tennis. He still does 150K per road bicycle per week and plays tennis some days per week. Therefore we try to perform an osteotomy. And the rationale for that was we did a double level osteotomy to correct the varus deformity of the femur and the tibia. Then we also performed a slope correction to 9 degrees to improve the extension. Because the patient had a extension deformity. You saw it on the previous slide, and we did the biplanar osteotomy with a descending set and cut, not to change the patellar height, because this patient had this patellar baja. So our goals were to improve the load distribution to unload the medial compartment, of course, but also to improve the extension, the range of motion toward extension, to decrease the loading on the patellofemoral joint. And also we try to improve stability by decreasing the slope and to leave the patellar height unaffected. And this was performed by this double level osteotomy with this descending tibial cut. Yes, and this procedure has performed 5 years ago. You can see this patient today. This was the last season, still free of pain, still 150 kilometers race biking per week and 2 times playing tennis per week. And he still played tennis on a competitive level. Yeah, so this is an extreme example, yeah, but it shows us how far we can go with the indication for osteotomy, especially in younger patients, because we can not only influence the varus valgus or the varus valgus loading, we can also influence posterior slope to improve the instability and also improve the range of motion. Yeah, in this case, to unload the patellofemoral joint. And here you can see this individual result. What about results from the literature? This is a Cochrane review, and this review has shown that with HTO we have a significant improvement of pain and function. There was no difference between the closed wedge, lateral closed wedge, and medial open wedge osteotomy regarding complication rates. But 2 studies compared HTO to UKA. There was no difference in pain and function after 7.5 years, but more adverse effects in the HTO group in comparison to UKA. But in conclusion, these authors concluded HTO reduces pain and function patient with medial osteoarthritis and varus deformity. If we have this conclusion in a Cochrane review, yeah, we can be sure that we have enough evidence, scientific evidence for this procedure. Critic was there's no study with an operative control, but 3 years later, the study was published. It was a non-randomized control study. In the study, 2 groups of 2 randomized studies were mixed, and HTO, 3 groups were mixed, HTO versus brace versus non-therapy, no therapy, usual care. So in the study, pain after 1 year after HTO was lower than after valgus bracing alone. And when we compared HTO to usual care, there was also a difference in pain and function. So this is the comparative study which was lacking in the Cochrane review. Yeah, when we look to long-term results, we see these are several long-term studies, and these studies show that the 10-year survival rate ranges between 81% and 95%, all open wedge HTOs with an angular stable plate fixator. And here we can see that that's a clinical results, PROMs increase from preoperatively to postoperative to the first year postoperative, but then we have a little decrease of these scores from year 1 to year 2, but the scores are nearly maintained equal. Return to sports rate is 87, return to sport to the same level, 76, and back to competitive sports in 54% of cases, back to work 84%. So in conclusions, indication for the medial open wedge osteotomy is a younger active patient with an additional with an osseous or bony tibial varus deformity and medial osteoarthritis. I think the medial open wedge osteotomy is the gold standard for correction of tibia vara. We have to perform careful preoperative planing, posterior human retractor, osteotomy inflection, aim on the tip of the fibula, cool the saw, avoid posterolateral hinge. If you want not to increase the posterior tibial slope, then the posterior placement of the spreader is important, and the angular stable plate fixator for osteosynthesis. And we have seen that the medial open wedge osteotomy is an evidence-based surgical procedure for the treatment of medial osteoarthritis with encouraging clinical results and long-term results. Thanks for your audience.
Thank you very much, Prof. Prof, you can stop sharing actually. Thank you very much, Professor, for this brilliant presentation and great cases as well. Prof, few questions from our side.
Yeah.
Prof, do you always get an MRI before you do this? Because do you look for the lateral compartment arthritis before you undertake an osteotomy?
Yes, most patients come already with an MRI to my clinics, and then I always have it. I think it's necessary to check the lateral compartment, to decide you should do an arthroscopy. In most cases, I perform an additional arthroscopy, but yes, most patients get an MRI.
And when you do an arthroscopy, if you see significant cartilage defects, higher Albert grades, would you still contemplate with doing an osteotomy?
At the lateral side?
Yes.
Yeah. It depends a little bit on the case. If I have a defect or cartilage damage of up to second degree cartilage damage, I would ignore it and do it. And in these cases, I still do an osteotomy if I have a large amount of correction. Then I try to not to overcorrect this patient to create not too much loading to the lateral compartment. But I would accept a second degree cartilage defect or a little. If I have a higher degree cartilage defect, maybe it's third to fourth degree, then it should be a very, very little localized defect. Then you can also perform an osteotomy, and it should be asymptomatic.
Thank you.
No pain on the lateral side, but we should also know that pain on the lateral side is in most cases of these various deformities is from the traction or from the tension on the lateral ligaments. Therefore, it's very difficult to differentiate this tension pain from articular joint line pain from the cartilage defect.
Thank you, Prof. And Prof, whenever you do a medial opening wedge osteotomy, do you use a bone graft to fill or use any kind of bone graft substitute or just leave it? Or is it dependent on the degree of correction?
It's dependent on the degree of correction. If I have more than 10 millimeters, I apply bone graft. I use allogenic bone chips. I do not use bone graft from the Lea crest. Was this we have good experience with this allogenic bone chips, and the rationale is not only, as I told you in the talk, not to promote bone healing, but also to prevent bleeding and hematoma and postoperative discomfort and pain.
Thank you very much, Prof. And whenever you do a medial opening wedge osteotomy, most of the time your semitendinosus and gracilis is at that location. So how do you address these tendons?
What do you mean? If I leave
do you incise it, or is it injured, or is it repaired, or how do you address the semiti and gracilis?
Yeah,
Does it
if
come
I
into
have,
this field?
I'm in the normal osteotomy case, I leave them intact. If I have to spread also more than 12 millimeters, then sometimes the tendons become pretty tight and also apply overload or hypercompression to the medial compartment. Then in those cases, you have also performed an additional release of the hamstring tendons.
Thank you very much, Prof. And Prof, is there any difference between there are several fixation options available, right? There's a Tomafix plate, and you have shown a plate, and also there's a Pudu plate. Do you think there's a difference among these, or even suppose these plates are not available suppose someone is watching from another part of the world and he does not have access to any of these modern plates? Do you think a simple medial side locking plate would do, provided the alignment is restored?
Yeah, it should be a locking plate, of course. I think it's important if you do this open wedge osteotomy, it's important to use a locking plate. There are other techniques described, such as the use of an external fixator, for example. I have no experience with that. But maybe in this case, when there's no locking plate available, then I would do a lateral closing wedge osteotomy. That's then maybe the better option.
Thank you very much, Prof. Prof, we are also joined by Loy Al-Khatib. Loy is an orthopedic surgeon based in Dubai. Loy, welcome to the show.
Hi, thanks, Prof, for the comprehensive presentation, as always. What I really want to stress on tonight is before you do the valgus stress, before you open the osteotomy site, make sure the osteotomy is really complete. Otherwise, you will end up with a fracture and the disaster will start. My question to Prof. Petersen is about the bracing test. How long you are putting the brace or doing the brace test before you go to the osteotomy? We know that all literature says at least 12 weeks. Do you agree with that time period, or you said, okay, well, we can have it into 6 weeks? What do you think about that?
Yeah, I think 4 to 6 weeks is enough. But the brace test is, for me, it's more a test to convince the patient, because as I told you in my talk, the brace can only correct the ligamentous part of our deformity. And if we have a patient, for example, with a pure bony deformity, then the brace test or the brace has no effect to unload the medial compartment. Yeah. Therefore, I think the test is not very reliable. It's very good, or it's good when the brace test is positive, and the patient sees an effect. Then the patient can see, okay, when we perform a permanent correction of the deformity, that could be beneficial for me.
Benefit of osteotomy.
But it's not in most cases, it's not a test for me.
For the patient, I agree. Okay, that's a good point. What a good point that you just mentioned is the chips is just not only for the healing, for the hematoma that comes out and pressing with the neurovascular bundle posterior. This is a good trick. Thanks again. One of the questions that always has been asked about the cutting point. Do you have any tricks or tips just how to measure the cutting point, where to start, and what level do you go? Do you start anterior, do you start mid tibia, or do you start posterior tibia regarding the cutting board from the joint line?
You mean the distance to the joint line, or
the distance as you showed is 33 centimeter. Some literature says up to 5 centimeters safe. You can do that. But when you start with the saw, you start
anterior posterior direction.
Anterior posterior direction is okay. That's you answer that. But you start where do you end your osteotomy to start with the ascending osteotomy?
Yeah, I put my Homan retractor below the patellar tendon, into the infrapatellar bursa, and I tried to aim my my osteotomy towards this Hohmann retractor, so it ends, just shortly over the insertion of the patellar ligament.
So you finish your osteotomy first, or let's say the frontal osteotomy first, okay? And then you pay attention for the ascending.
Yeah,
So
I start with the frontal osteotomy, but I know several colleagues who start with the ascending part of the osteotomy. This is also possible. Yeah. My clinical practice is to start with the horizontal osteotomy first. I always cut under the guide wires. It's also to prevent the hinge fracture to the joint line.
Awesome. And what about your post-op rehab protocol? Do you, as we know that the Tomoflex plate will allow them immediate weight bearing, do you agree with that, or do you have a different rehab protocol for these guys?
Yes, I showed you. If I have a normal weight patient, this is BMI until up to 28. Then I do partial weight bearing just for 2 weeks, 2 or 3 weeks. After 2 weeks, I allow them to move with full weight bearing, but most patients still need 3 weeks on crutches because of pain, discomfort, etc. And this is fine for these patients. If I have overweight patients or patients with a hinge fracture, and the hinge fracture, hinge fractures can be a cause for malunion. Then I do a little bit more careful rehabilitation, and then they go with partial weight bearing for 6 weeks.
Wow, awesome. I think that's it for tonight. There were the questions.
Thank you, Professor. Thank you, Professor. I think that's all the questions that we have for this session. Thank you for this fantastic presentation, and I'm sure this is going to benefit a lot of people. Thank you so much, Prof.
Yeah, thank you so much too for the invitation.
Thanks again. Thanks for joining us.